tutoring session. Okay, so we're recording. Okay, first I want to start off by saying thank you to everyone that sent me messages regarding your prayers and concerns about my mom. It was a long surgery, I want to say about 8 hours. She just left ICU today and she's on a regular unit. So she's doing a little better. A lot of vertigo and nausea, but for the most part, she's doing much better. So thank you guys for, just having patience with everything. I know things have been slow moving this week with class as far as me posting things. But again, I just want to thank you for your prayers. Thank you for your concerns. And most of all, thank you for your patience with me getting stuff posted for you guys on Blackboard. So I am holding this tutoring session tonight because I want to make sure that we are comfortable with everything, getting prepared for the midterm, as well as making sure that everyone's on the same page with understanding what's going to happen for the next 2 weeks. So with announcements that I have for you, oh, thank you so much, Kendra. Making sure that we are all comfortable, okay, with what's going on. So first thing, because we are using a different platform for this tutoring session, I just want to make sure you guys understand with Zoom meetings, as you can see, you have the ability to share your webcam, which a few people are sharing. Hi, Laura, I can see you. And so you can share your webcam. However, as far as your audio, I will tell you to please mute your microphone. As a facilitator, I will always have on my microphone as well as my webcam, but you guys do not need to turn on your webcam unless you want to. It's fine. I like seeing your face. It makes me feel like, someone else is in the room with me. But if you can please make sure you mute your microphone, because that part is very important. Because sometimes when, someone does not mute their microphone, oh, Laura, you can't hear. One second. Can everyone else hear me? Okay.
Yes, I can hear you.
Okay, great. Thank you. Let me just send a message here to Laura because she's having some issues. Give me 1 second.
I didn't realize we'd be able to see each other. I should have gotten dressed. So
oh, don't worry. I just threw on a sweatshirt, so don't worry. We're all home and comfortable right now.
Yikes.
Okay, so hopefully she can get that together, but I'm gonna keep moving. Okay, so again, just to confirm, it is extremely, extremely important for everyone to please turn off their microphone. If I see that your microphone is not turned off, I will mute you because I can mute you on my side. It's very important because it will give a lot of feedback, and I am recording this for those people that are not able to, attend this particular tutoring session so they can watch the recording later. Okay, so we just want to make sure that everyone is, and someone has their mic on. I don't know who it is. Okay, I think we're good to go now. Okay, so again, what happened to someone? This is what happens when I'm doing a new platform. I don't know if it's Micah. I'm gonna mute this person. Okay. 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 So we should be good to go now. Okay. So again, just a few announcements before we get started. For those people that are in the Monday section, I don't know if anyone on this tutoring session right now was from the Mondays class, but for Monday class, excuse me, Monday morning, as well as Monday afternoon, just to confirm for this upcoming week, for week 5, you guys will take your cardiac quiz and your midterm together on Monday. Okay. Unfortunately, there was no way that I could, have you guys do it at home or move it around because it would really, really put us behind. So that's the only way that I was able to kind of get that together for you. If you guys notice, for your week's 4 topics, I dwindled that down to one particular chapter, which was chapter 22. That information should help you for your check your understanding questions for week 4, as well as your discussion board questions for week 4. So that information you should be okay with. I was trying to make sure that, everything was comfortable for everyone. I didn't want anyone to feel like, oh my gosh, we have, tons of chapters and, she's not here. So I just wanted to make sure that everything it will occur. Yes. So Liz, just to answer your question, yes, it will be back to back. So when you guys come in next week, and this is for all sections, when you come in next week to class, you will come in and just take your exams only. There will be no substitute as far as an instructor. You will be taking your exams with the proctors. The proctors will set everything up for you. So for those of you who are in the Mondays class, you will come in, you'll take your quiz first, and then right after, you'll take your midterm exam. The midterm exam in the quiz, so I think they're probably going to give you both codes at one time. I'm not sure, but I would highly recommend, please, 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 for those of you who are in the Monday sections, I would highly recommend that you take your cardiac quiz first and then take your midterm exam right after, and not the other way around, because you will most likely see the same topics, even maybe the same questions that will be on your midterm exam. Okay, so it's going to be easier for you if you take your cardiac quiz first. Okay, so I just want to clarify that. Okay, so again, when you guys come in next week, it'll be just examination only. I will have everything posted for you prior to that day, so just everyone knows, okay, where they're going, what's going on for midterm exam day. You will also get information once you leave your exam that evening, for your new topics for the upcoming week. And, we'll be back to business as usual. Just to also confirm for next week's midterm exam, my goal was to try to have the midterm exam scheduled as soon as you walk into class or when class time starts. Unfortunately, I am not able to do that. The proctors are not available at the beginning of the class time, which means that the exam schedule, I'm going to read it out now, okay, because he emailed me. I'm going to read it out now, but I'm also going to post this as an announcement, so don't worry if you don't get it down. For those people that are in the Monday morning class, your midterm exam will start at 10 a.m. For those people that are in the Monday afternoon class, your midterm exam will start at 2:30 p.m. For those people that are in the Tuesday evening class, your exam will start at 7:30 p.m. For those people that are in the Wednesday evening class, your exam will start at 7:30 p.m. Okay. Unfortunately, that's the only time that they have in their schedule to accommodate us. I'm sorry, that's the only thing that they gave me. Okay. And so the times that I just gave you are the times that you will come in for your exam. So you don't need to show up at the start of class. As far as the attendance code and marking down for attendance, you will not be given an attendance code that day. I can't get it out. You will not be given an attendance code that particular day. I will actually put in your attendance manually. Okay, so I will mark your attendance according to your exam. Okay, I have a question about that. Give me 1 second. Let me see the question. No, Laura. So you do not need to get to school at 5:30. So as I just explained, and let me say it again, the times that I just gave you, and I'm going to put this in an announcement very clear for everyone because I don't want any confusion. The times that I just read off are the times that you will come to class. So that's going to be your class time because you're only coming in to take your midterm exam and that's it. So you don't need to show up at the time that your class time starts. As far as attendance is concerned, I will manually put in everyone's attendance according to, the exam. Once I look in Blackboard and I see that you took your midterm exam, I will manually put in your attendance on my end. So you don't have to sign in. You don't need to check in with the attendance code or anything like that. I will take care of it manually. Okay, so hopefully that makes sense. Again, I will put this information as an announcement, so don't worry, you will get that information most likely between tonight, tomorrow, sometime soon, okay? So everyone knows how to prepare themselves, okay? So you don't have to get to class on time. You have a little more time to kind of get together and, get prepared for the midterm, okay? Trying to think any other announcements. I went over the week 4 information, midterm exam. So I did post an announcement with the midterm exam review layout with the, all the information to get ready for the midterm. I did post an older midterm review video. However, which is why this tutoring session, I'm going to go into more detail and just kind of focus on that. And then I'm trying to think what other announcements. I think that's about it. And then once we get back to, once the final, not the final, I keep saying the final exam. Once the midterm exam is done week 5, just to make you aware, we are going to go back to a 5-week chapter. Okay. The chapters that we missed for week 4, 23, 24, and 25, I'm going to use those topics to incorporate for our online, well, not online, I'm going to use those topics to incorporate for our signature assignment. I will go over that later. I don't want to, put too much information in your head right now. Okay, you posted something on previous midterm somewhere on Blackboard. Yes, I posted a midterm review. I actually did a, I don't know whose name this is, someone 273 number. I posted, yes, I did post something on, I don't know who that is. Someone's chatting and I'm not sure what's going on. Anyway, just make sure that you guys look at your announcements, okay? Because as you guys notice, especially with me, not being in California at the moment and just kind of transitioning it, with everything. Oh, Patrick. Okay, Patrick. So yes, Patrick, just make sure you look at the announcements. I did post a midterm review. Like I made a whole web page about the midterm review. I posted that, I want to say like 2 or 3 days ago. So if you can, or maybe it wasn't 2 or 3 days ago. Maybe it was, I can't remember. The days are just all mixed together for me. But just make sure you please look at your announcements. As you guys notice, I always post at least 2 to 3 announcements per week. And it's, obviously important information. So just make sure you look at your announcements. Okay, so Madison, for the Monday section, get in there at 2:30 will give us enough time to complete the quiz in the midterm. Yes, it will. So for the quiz, you have 30 minutes for the quiz. 20 questions. Your midterm exam is 70 questions, and you are allotted, I forgot how many minutes. It's usually a minute per question. So, but I think they have you guys down for 70 minutes or 90 minutes. I can't remember exactly. But you do have enough time. So at 2:30, let me see, hold on a second. I have you scheduled from 2:30 to 4. So 2:30 to 4. So you have an hour and a half to answer 20 question midterm, 20 question quiz and a 70 question midterm. Okay. So again, I'm going to post all of those times in a separate announcement. Okay, so don't worry. I will put that information again. Okay, so let me get right into the midterm exam layout and review. So this is what I want to focus on. So this information is extremely important for everyone. Keep in mind, for those of you who are in the Monday section, you guys will be taking your cardiac quiz with your midterm exam, okay? So you want to pay close attention as well to this tutoring session, because I will be reviewing cardiac topics as well. So this is kind of all in one for everyone. Okay, so our midterm exam will include chapters 1, 2, 4, 7, 10, 11, 13, 14, 15, 16, 18, 19, and 20. Okay, so let me just do a little screen share here. Just give me a second. So I just want to do a little screen share just to show you the web page that I posted. And I just want to use this as a platform to go over the layout. Okay, so for the midterm exam, just to confirm, same platform as we normally take our weekly quizzes in class. So you guys will be using your personal laptops. We will be using the Blackboard Lockdown browser. For those of you who do not have access to a laptop, don't worry, we have loaners there for you. The midterm exam will consist of 70 questions. Keep in mind it is cumulative for the first half of the course. As you guys notice, I did divert from the syllabus, which means that we are only going up to chapter 20 for the midterm exam. The total midterm exam is worth 90 points, okay? Also, table 7.1, 7.2, 16.2, and box 20.1 are also very important to review for the midterm exam. So let me just stop there and give a little more clarification. Table 7.1, if you remember, this is focused on the chapter on cancers. And so for this particular chapter, we focused on a lot of different things. But for this table, it gives us a few more characteristics of how to distinguish between benign and malignant tumors. 7.2, remember, is the table that goes over all the different types of cancers, which shows us how to use the nomenclature OMA and sarcoma and carcinoma. Remember, I do not need you to memorize each and every exact cancer, but I do want you to be able to understand what it means when we look at the suffix OMA, carcinoma, and sarcoma, so we can distinguish between benign and malignant tumors. Table 16.2, these are the only tables, or I should say, these are the only numbers that I'm going to have you guys memorize for this term. Please make sure you memorize the normal blood pressure reading, what's considered prehypertension numbers, and you should also memorize what's considered stage 1 and stage 2. Okay, so that information is very important to know. Box 20.1, this little table or box covers what we call the different types of shock. So it is important to know the 4 categories of shock as well as the examples that fall under that category or those categories. We will have a question on that. Now, the next section here says to review A&P topics for blood and cardiac. So let me go into a little more detail with this. So as you guys noticed in chapter 13, when we covered anemias, I did put some information as far as normal anatomy and physiology of blood. One thing that I will say is that I will have some basic anatomy and physiology questions on the midterm when it comes to blood and cardiac. So let me give you more detail. I would definitely focus on what are blood cells, the different types of blood cells, and the functions. So in particular, we should be able to distinguish, okay, what's a red blood cell? What's the function of a red blood cell? We should also be able to distinguish the different types of white blood cells. So going back to anatomy, okay, we had our granulocytes, our agranulocytes. Under our granulocytes, as a refresher, we have our eosinophils, basophils, eosinophils. Oh, sorry, I said eosinophils. Eosinophils, basophils, neutrophils. Okay, the fill family. So we should know that information and know what the functions are. It's not, how can I say? That could be something I can put as a test question. Okay, even though that was anatomy and physiology, but in patho, I need to make sure that you guys know that information, because as nurses, when you start looking at labs, okay, you'll be looking at labs all the time. And if a patient has elevated neutrophils, we need to first understand what's the function of a neutrophil in order to understand why the patient's neutrophils are going to be elevated. So we want to make sure we go back to the basics. The next thing we want to focus on are the agranulocytes. So under that category, we have our site family, which are going to be monocytes and lymphocytes. So we should be able to easily know what these cells are, the function, and even with lymphocytes, how to break those down into B, T, and natural killer cells. Okay. And this information that I just went over is not only important for chapter 13 and for, when we talked about blood type disorders, but it's also very important for chapter 11 as well, when we discuss leukemias, because this information came up again, okay, in that chapter. So trying to think, what else did we discuss? I think also in chapter 13, we went over like how red blood cells are made and, their life cycle and what happens when they are destroyed and, things like that. So I would kind of focus on that as well. I will also, when it comes to cardiac, very, very important that you understand the flow of blood circulation, okay, through the body. What happens with blood in and out of the heart, what we consider right-sided circulation or left-sided, or if you want to call it systemic versus pulmonary circulation. So you should definitely know that information. I guarantee you there will be some sort of test question with that. If it's not a direct test question with anatomy and physiology with that information is very important to understand the concepts when it comes to heart failure. So when a patient is having heart failure and the right side is failing or the left side is failing, that all again stems back to the flow of blood. It is also important to know microcirculation. So when we discuss arteries and how they break down to arterioles, and then the next area is a capillary, and then from a capillary, venules, and then veins. Okay, so making sure we also review that order. Okay, trying to think what else. Cardiac. I think that's it for right now that I can think of. If something else comes up, I'll add it in for the chapters. So the chapters are listed here, as you can see, 1, 2, 4, 7, 10, 11, 13, 14, 15, 16, 17, not 17, excuse me, 18, 19, and 20. Okay, so let me pull up, give me 1 second. So much going on this computer. Okay, so to get started, chapter 1, this is our basic chapter, okay, in a sense where this chapter focused on just basic terms with patho, just understanding certain things. So I'm gonna just kind of go through this really quickly and just kind of give certain highlights, okay? So for chapter 1, I would say overall, just make sure you cover all the different patho topics. Make sure you understand the functions, or I should say the definition of each term. I feel like everything is just running so slow. Okay. So making sure that we cover each term, I would say, excuse me. I would say make sure you cover each term. Make sure you also understand the examples that correlate with each term. A couple of things that I would throw out here is making sure you understand the difference between a sign and a symptom. Understand the difference between the etiology versus a risk factor. We should definitely understand what happens when a person has an exacerbation versus remission. A couple of other topics I can think of, kind of going through all of this. Oh, definitely latent and prodromal. Okay, if you're not too comfortable with that. Someone has their mic on. If you're just joining us, can you please mute your mic because this is being recorded and so it gives a really, really bad feedback. Okay, thank you. So we can definitely go over this information, latent versus prodromal. I think two concepts sometimes can be a little confusing, such as iatrogenic and sequela, understanding what a syndrome is. So I think this chapter, everyone was pretty, okay with. We can go over these terms as well here as far as epidemiology is concerned, and then just making sure we understand what the different levels of prevention are, and also really important, making sure we know how to correlate this to an example. Okay, so does anyone have any particular questions from chapter 1 before I move on? I know chapter 1 tends to be a little easy breezy chapter. Okay, so I know there's some people that's joining, which is great. Happy to see you or hear from you. However, if you guys don't mind, please putting your microphone on mute or your phone on mute if you're calling in, because I am recording this session, so there's not a feedback. Thank you. Okay, so for chapter 2, this is another chapter I felt was just kind of easy breezy, little, kind of focused here. So for chapter 2, when we discuss stress, okay, and how the body responds to stress, I would go over the definitions of homeostasis versus allostasis. That's important to focus on. And just to elaborate a little more on allostasis, sometimes when people look at this term, they're not quite sure what's happening, what exactly does this mean. But allostasis means that the body recognizes that we're outside of homeostasis and it will start to implement, or I should say, kick in certain mechanisms or compensations to bring the body back to homeostasis. So whether that's triggering the immune system to do something or whatever, it's now trying to bring it back to normal. Okay, so that's what we call allostasis. A couple of other things here with chapter 2. We should understand the different types of stressors. I want to say we focused on chemical, physical, and emotional. We should also understand the phases. Well, I can't think of it now. Just forgive me, I'm running off of a little bit of sleep. Oh, here, this one. The general adaptation syndrome. So we should know the different stages. Okay, so we should go over this information. Once we get past this, it breaks down the information according to different body systems and what is actually secreted. So when you're studying for this chapter, if you want to kind of break it into different areas, such as like immune system and the endocrine, and then maybe nervous, and then just kind of write down the things that will be secreted under each system, then I think that's an easier way to memorize the information. So I would just memorize everything that's going to be secreted within those systems, and I think you should be good to go, okay, from there. Okay, let me see if there's anything else. Yeah, as long as you know everything that's being secreted, you should be good to go for this chapter. Okay, so does anyone have any particular questions for chapter 2? Okay, no. Okay.
Under the different stages, like for the alarm stage, should we know that like cortisol is secreted? Should we know like the different hormones that's secreted?
Hold on one second, I'm sorry. So yes, I would, yes, you do need to know that.
So know like each stage, like which stage.
So as far as the stage, it's just kind of making sure you know what's happening in each stage. So say for example here for this slide, number 5, if you can look at like the stage of resistance, just kind of understanding that the activity of the nervous and endocrine systems returning back to homeostasis, okay? These systems are going to be involved, okay, when it's time when we talk about stage of resistance. You should also take a look at this one, stage of exhaustion, where the body can no longer return back to homeostasis. So just kind of understanding like what's happening in each stage. So I don't remember actually from like the first quiz having direct questions from that information, but if you, I would just go over the stages just so you can understand like just the definition basically of what's here.
Okay, got it. Thank you.
Okay, no problem.
I was doing studying as if like I needed to under like each stage know which hormone correlates with each stage. So don't worry about that part. Just
oh no. I don't need you to know which hormone correlates with each stage. I'm not going to get that detailed. It's just a matter of knowing what can be secreted. So like, you know, catecholamines and, you know, endorphins and Keflon. So just kind of understanding like what could be secreted and just kind of knowing when those items are secreted, which system it's coming from. Okay, so we don't want to say, oh, endorphins and Keflons are coming from the immune system, you know. So just making sure we know which system they come from. They come from the nervous system for those. So just as an example. Okay, so I have a few more questions here. Okay, so Melissa, so all of the hormones on the outline. I don't know which outline. Yeah, I'm going to say yes. Yes. Make sure you know all the hormones that are listed in the PowerPoint. Hormones and, you know, they have other neurotransmitters and things like that, okay, for this one, or for this chapter. Okay. So there's another question. This one, not sure what you're referring to other than chapter 2. Okay. Okay. Yeah, I'm on chapter 2. I don't know who's not following. Yes, I'm on chapter 2. The PowerPoint that I have up right now. Can you guys see my PowerPoint? You should be able to see it. Okay. So yes, I'm on chapter 2 PowerPoint, if you can see that. Okay, thank you. Okay, so that's that. Chapter 4. Okay, so chapter 4 focuses on cell injury, aging, and death. Okay, so what do we all mean by this? This chapter really focuses more so on cell injury. So just to kind of break things down for you, as I said when we were, preparing for that quiz, it is important to, I would say, divide this information into what we call reversible versus irreversible cell injuries. If you can make certain columns or 2 columns like that, excuse me, that would be good, okay, to just kind of organize your material. So to get started, for the reversible cell injury, under this one, I want to say the very first one we discussed was hydropic swelling, and this is probably one of the most common types of reversible cell injury. I would know everything about this, so it goes into detail as to what's happening on the cell membrane with the ions and so forth and swelling. I would go over everything with that, okay? And I think that was also a question with one of our quizzes, the first quiz, I should say. Oh, speaking of the questions, for the midterm exam, just as a side note, I don't know if I said this before, but it is a possibility you will have repeat questions from your previous quizzes. However, you could also have new questions as well. Okay, so just make sure you guys cover all the material. What happens is I have a question pool, so I just kind of, pool in different questions. Everyone has a different, exam. Your exam will be 70 questions and it may be out of a, 100 question pool or what have you. So just make sure you do cover everything, but it is definitely a strong possibility to see repeat questions as well. Okay. And so sometimes people like that. Okay, so now continuing on with reversible, it is important to also take a look at what we consider intracellular accumulations. Under intracellular accumulations, we do have a few items here, such as things that can happen for faulty metabolism, things that can occur when we have too many toxins getting in, things of that nature. So I want to say it broke down into like 4 maybe additional items. So I would, take a look at that information, very important. Okay. Also under reversible cell injury, we included what we call the cellular adaptations. And with cellular adaptations, this includes atrophy, hypertrophy, hyperplasia, metaplasia. Dysplasia is part of cellular adaptations, but remember, we're going to put dysplasia on the irreversible side of things, okay? So, however, going back to the first 4, please make sure you know in detail, well, it's not too much detail, but just make sure you know how to describe or what is considered atrophy, hypertrophy, hyperplasia, metaplasia. It is important to be able to just know the description of what the cells will look like if someone has one of those. You should also be able to kind of use an example as well. And I think I gave you guys some examples in the video for that week. Okay, I think that's important to take a look at. And I would say that's about it. So as far as irreversible cell injuries, we have definitely dysplasia. So dysplasia falls under that category. Remember, and I explained this before in class, dysplasia is considered irreversible because if you leave it alone, it's not going to reverse on its own. It has to be medically treated in order for reversible, or in order for it to possibly reverse. I'll put it that way. I think I gave you guys cervical dysplasia as a very good example for that. Everything else okay, such as atrophy, hypertrophy, hyperplasia, metaplasia, they all are considered reversible because if you remove the stimulus, they could reverse back on their own. Okay, so we want to just kind of look at it that way. So going back to the irreversible category, we have dysplasia. The next information under that, we have necrosis and gangrene. Keep in mind, just so we're not in any confusion with this, I will never put a test question where we would have a necrosis and a gangrene all together in one question. I would either give you necrosis topics or gangrene topics, okay, but not, both, because, in essence, they really mean the same thing, okay? However, it's a little easier for me to focus on the necrosis because that information, it has more detail that I gave to you in class. So as far as necrosis, I would pay attention to understanding what or how to define what is coagulous necrosis, how to define what it is liquefactive necrosis, caseous necrosis, and fat necrosis. And I think I also gave you guys the body regions, or what are some examples that you can see with those types of necrosis. Okay, so I would definitely take a look at that. We could easily have questions with that. Okay, and I think that kind of ends before. Okay, does anyone have any particular questions with chapter 4 before I move on? Uh-oh, what happened to chapter 7? Can't pull it up. Okay, so for chapter 7, this was everything about cancer, okay? And as I told you that week in class, and I'll say it again, make sure you know everything, okay? I know it was a lot of information, but I just want to kind of give you a layout pretty much of what to focus on here, or I shouldn't say what to focus on, but just more of a layout as to how you can, break down this information, okay? So one of the first things we discussed in this chapter was how to define or differentiate, excuse me, a benign from a malignant tumor. Okay, so please make sure that you go over the characteristics because, there's different ways that we can distinguish a benign tumor versus a malignant tumor. Just by, the shape, the size, is it spreading through the blood? Is it more blood vessels or not? So just kind of things like that. So I would definitely look at the characteristics, okay? And just as a side note, the reason why knowing this basic information is important because you could have a test question about a particular cancer even though we haven't gone over that cancer in detail, just from the information based on chapter 7, as far as, making sure you know the nomenclature and the characteristics and, things like that, you should be able to answer those questions, okay? So keep in mind, table 7.2 also gives some additional characteristics that maybe in this PowerPoint or may not be, I'm not sure, but just make sure you also look at table 7.1 and it gives some characteristics there. Now, the next thing we had was going over the nomenclature, how we name cancers, so understanding how the suffix is used. So anything that ends in oma is considered benign. Anything that ends in carcinoma or sarcoma is considered malignant. Please understand that when we look at carcinoma and sarcoma, the entire thing is the suffix. And sometimes people get this confused. Even though it has oma in it, we don't just target the oma only. The entire thing, carcinoma or sarcoma, they're considered malignancies. So keep in mind that anything that's considered sarcoma is going to be of mesenchymal origin, such as anything that's like bone or muscle or any kind of soft tissue structures. Whereas anything that's considered a carcinoma is going to be considered more for epithelial type cancers. Okay, so we should know that information. Moving on, I think we went into, and I'm trying not to lecture on this, but trying to go through this quickly. Risk factors, I would look at this. I think we all have an idea what risk factors are for cancer. Metastasis for sure. I would know a lot about tumor markers. Okay. Keep in mind, just as a reminder, if you were watching older videos, I do not need you to memorize table 7.6 or 7.7, whatever that is, with the tumor markers. But however, I do need you to know the information on this particular slide. Okay. Understanding what is the purpose of a tumor marker, understanding why we use it, how it's detected, how do we even find a tumor marker. Okay. So we should be able to know this information that's on the slide here. We should understand angiogenesis and what happens when we have a lot of blood vessels surrounding tumors. Definitely grading and staging. I can easily have a test question with this. Okay, so remember, grading is looking at the histology in the slides, okay, from a lab, whereas staging is looking at the patient as a whole and the extent of tumor spread, basically. Warning signs for cancer, I think I already told you about this, making sure you know the acronym. I will now have a direct test question with the acronym, but I would say it would be good to have it in memory. You may see it somewhere else. Also, warning signs for children. I think we understand the common theme here is that it correlates with some of the, day-to-day childhood disorders. Pain, as far as side effects, or I shouldn't say side effects, but signs and symptoms that patients could have with cancer, such as the immune system issues, loss of appetite, increased metabolic rate, nausea, vomiting. Please make sure you know bone marrow suppression. And sometimes this gets overlooked for some reason. Okay. Bone marrow suppression is not only just linked to leukemias. Okay. Oh, and speaking of leukemias, I forgot to go back. Going back to the nomenclature, remember, we do also have exceptions to the rule. So remember, lymphoma is an exception to the rule. Leukemia is in a class by itself. And I think there's another, excuse me, there's some other exceptions like hepatoma and another one. Okay. But definitely I would focus on lymphoma and leukemias. Now, bone marrow suppression. We should all be comfortable with this by now. If you are not, please make sure you read this. Because when a patient has cancer, the problem is this. The bloodstream, blood vessels are all going to be decreased, now leading these patients into secondary conditions. You should also know the secondary conditions it could lead to. Now, even though we have these names here and it's not quite in order, so to speak, okay, but let me help you with terminology. If a patient has a decrease in red blood cells, we call it, you may not see erythrocytopenia, maybe, but they'll just jump right and say anemia, okay? So with anemias, we know that this is a condition. It's a whole nother chapter just on anemias, okay? Leukopenia means there's a decrease in white blood cells. Leukopenia is the finding of what the patient has, but now this can lead to secondary issues such as these patients developing possible infections because they don't have enough white blood cells to fight it. Thrombocytopenia is decrease in platelets, which means that these patients will not have enough platelets to clot the blood. So now when you see this in the lab work and you see that the patient's platelets are low, This is now going to tell you, oh, they may have some bleeding issues. So now you want to start monitoring this patient for bleeding issues. Okay, so this is the reason why, and I'm putting emphasis on this, and this is not just for test purposes. This is important for you guys as nurses clinically, because once you know this is going on, now you have to look at a whole nother assessment of things. Okay, then we have other effects here, okay, which we know all about, the hair loss and things like that. And then just making sure we know just general what the different treatments are. I'm not going to get so heavy with this, but just have an understanding of what the different treatments are. Oops. Okay. Does anyone have any questions with chapter 7?
No.
No, you're good? Okay. Chapter 10, I know I don't really need to go over this. I think everybody has this together. Okay. But just to kind of quickly clarify, for chapter 10, remember this focuses on hypersensitivity disorders. They're divided into 4 different types. Make sure you know the following information that I'm explaining to you. Make sure you know the name of the type, okay? So not only just the number, but the full name. Make sure you know the mechanism behind it. So basically like what's going on, okay, with this topic. You should also know which cell is actually being mediated or secreted. And that's important to know, as well as the immunoglobulins, if it has any, okay? And the time frame and examples. Okay, so pretty much everything that's there. This chapter, probably one of the easiest because it was just kind of straightforward, 1, 2, 3, 4. Okay, you can't get any simpler than that. Okay, so does anyone have any particular questions from chapter 10?
No.
No? Okay. Oh, somebody's typing something. No. Okay. Thank you. I know I'm trying to hurry up so I can get to the good stuff like cardiac. I know. I know. Okay. So chapter 11, give me 1 second. I need a pillow because my back is hurting.
Talking to you? It's live, yeah. Let's just talking to you.
Okay, I was sitting in the hospital waiting room for like 2 days and it's not very comfortable. I need a massage right now. Okay, so okay, I'm getting some questions and comments here. Laura, no, cardiac is hard. Yeah, okay. Yes, I know. That's why I'm trying to hurry up through this so I can get to cardiac. And I think this is Patrick. Yeah, Patrick, I know. Yeah, I tried to, that was the best I can do. And so, yeah, we'll get it together. After next week, I'll be back. Okay. All right. So chapter 11, this chapter focuses on cancers in the sense where we're just focused on really on leukemias. And why does this keep popping? Okay. Yeah, no, that's fine. I understand. Okay. So for chapter 11, with leukemias and lymphomas, remember I was explaining to just kind of focus on, as far as the PowerPoint, the first 12 slides, I believe it was, because that information in the first 12 slides is not on the spreadsheet, and the spreadsheet just kind of focuses on the individual topics. So with the first 12 slides, it gives us the, whew, my back is hurting. The first 12 slides gives us the, you know, information, just kind of underlying information about leukemias, lymphomas. I would say make sure you focus on the lineage. So we discussed like the myeloid lineage, lymphoid lineage. We also discussed how, excuse me, these cancers are named, or I should say not named, I'm sorry, diagnosed, such as blood work, you know, looking at biopsies and understanding like what we're looking for in the labs. It also tells us overall, like the common signs and symptoms, okay, that can occur. We also went into detail understanding acute and chronic and how that correlates to immature and mature. Understanding the additional term for acute and immature is also the blast stage. So we kind of went over like some pretty good information with those first 12 slides, and then understanding treatment and what's the goal, you know, complete remission, and, you know, just kind of understanding the protocol is for, you know, for chemotherapy and bone marrow transplant, and understanding how that works. So I would go over that information because it, you know, can definitely be a single question, okay, with it, or that question could be incorporated, you know, very easily with, you know, the information based off of the individual leukemia, okay? So when it comes to the individual leukemias, so when it comes to individual leukemias and lymphomas, you know, you guys have this study guide that was provided for you with, you know, the breakdown of everything. Just to clarify, it is color coded, and I did give you a little bit of a guideline on how to follow this spreadsheet. So number one, you should pay attention to, obviously, the name, because the name of the leukemia or lymphoma can tell you a lot of information right there. So if it's chronic, we know, so just use CML, for example. If it's chronic, we know it's attacking a mature cell. If it's myeloid, we know it's attacking most likely a myeloid lineage cell, which could be probably the most abundant of the myeloid cells would be a neutrophil, okay? But it could be others. So, you know, just knowing the name alone could, you know, give us some information. Now, as far as this spreadsheet is concerned, the items that are in red are considered the hallmark. So this is something that stands out, which means that these are things that I would most likely have to put in a test question to help you identify this particular cancer. So hint, hint, okay? I would pay close attention to that. You should also pay attention to the items that are in black as well, because I feel that they could also, you know, be things that to distinguish between cancers. And then what's here in green are just basic, you know, common signs and symptoms amongst cancers, or these particular cancers. And trying to think what else I need to point out here. Multiple myeloma, we already know, okay? There's a lot going on here, which means that no one should get this wrong on the test, because it's totally different how it behaves than the others. Okay. And when it comes to lymphomas, we can easily compare and contrast. There's a few definitely similarities, but then there's also some differences between these two. Okay. And everything is listed here. Okay. So not to get into each and every detail, but at this point, does anyone have any particular questions on chapter 11?
Do you want us to know the symptoms for each cancer? Like the signs
So for
and
the
symptoms?
symptoms, the ones that are in green are kind of shared signs and symptoms. So even if you see that as in a test question, it may not be something that's going to really help you. if you do look at signs and symptoms, you should look at the ones that kind of stand out. So under the column where it has here symptoms, I would pay attention a little more to the ones that are in black than green, because most cancer is going to have, you know, fatigue, a bone pain, a weight loss, or something like that. But I would pay a little more attention to the ones that are in black because they may stand out a little bit from the rest. Okay. But however, for these particular cancers, I feel like the questions I have, I don't know if I have like tons of questions that are about signs and symptoms. However, you could have a case study question that includes the signs and symptoms within that question, but you're going to have additional items too that's going to help stand out. So like more so under the signs here where we have, you know, the presence of the Philadelphia chromosome and, you know, here the malignant immature, you know, so things like that will help stand out more. Does that answer your question? I'm not sure who that was. I'm sorry.
Yeah, that sounds great. Thank you.
Okay, great. Okay, so I think we're good here. And $13. I'm going to make this simple, simple, simple. Okay. 13, anemias. For anemias, we focused here on, and I think I told you guys, you can definitely divide this information into congenital and acquired. Okay, so so in this chapter, the first few slides, I don't know how many here, focuses on just basic anatomy, physiology review of blood and, you know, blood cells and so forth. I would look at this information. I know it was anatomy and we're done, but we're not. Okay. This information is going to carry over again and again and again. Okay. So I do want you to please review this because I will try to incorporate some sort of question from this information on your midterm exam. Okay. It is important to know. Okay, it is important to know. Okay, now getting into the different anemia types, and I'm going to try to sum this up as quickly as possible. I don't have tons of questions from anemia chapter, but I do want to focus on a few things. Anemias overall are kind of, you know, clear-cut understanding what the anemia type is, what's the deficiency. Those are the things, as I said, for that week's test that I'm going to focus on. So I would focus on under acquired iron deficiency anemia. I would understand anemia due to acute blood loss. I would understand anemias that are secondary to renal failure. And going back to iron deficiency, we should also know the other vitamins that could, you know, lead to, or the other, vitamins that help make red blood cells that could lead to, you know, these types of anemias if that happens. Okay. What else? I'm trying to think what else was acquired. I think aplastic was under acquired as well, so we can put that in that category. And just to confirm with aplastic anemia, this is where the term pancytopenia was introduced, okay? And then, you know, understanding that risk factors like cancer therapies can lead to aplastic. So remember, with a cancer patient, sometimes that patient can have bone marrow suppression, or they could lead to a pancytopenia, you know, from the cancer itself, or they can lead to a pancytopenia secondary to cancer treatment. Okay, so when you see the term aplastic anemia, pancytopenia also is part of that. Okay. When it comes to congenital type anemias, we discuss sickle cell, thalassemia, hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiencies, and what was the other one? I can't think right now. There was another one. Oh, hemolytic disease of a newborn. Hemolytic disease of newborn. Okay. So again, if you focus on the title, what's the deficiency, you should be good to go. Okay, so it's not going to be like a whole lot of, detailed information. Now, when it comes to polycythemia, it's the same thing here. Make sure you know the different polycythemia types and what's happening basically. And I want to say that we also have examples that are given within those polycythemias. So I would, kind of know those examples because that could be incorporated with a test question. Okay. So does anyone have any questions with chapter 13?
No.
No? Okay. Thank you. 14. I know this tutoring session is long, but it's okay. I want to make sure you guys are comfortable with everything. So I'm doing an overview, but just whatever questions you have for me, just, let me know. Okay, so for 14, as I said before, I don't have tons of questions with 14. There are particular things that I am focusing on with this chapter. So, number 1, please make sure you know what we use, or I should say not what we use, but the importance of patient history and intake and all of that information that we need to check to see if someone's having a blood coagulation disorder. Okay, so such as understanding if they have a family history, if they're bleeding, or medication history, so things like that. So understanding how that correlates. We should also know the labs in a sense where what are the lab studies, not the numbers, but just the lab studies. So the lab study that would be performed would be blood coagulation assessment. Under that blood coagulation assessment, we have PT-INR, APTT. It wouldn't hurt to know bleeding time as well, okay? And I'm trying to think, was there anything else? Okay, so making sure we know the lab studies. We should know how to distinguish what PT-INR is assessing for. What is APTT assessing for? Okay, not the numbers, but just what is the purpose of the lab? As far as disorders, we should pay attention to hemophilia. We should also pay attention to, I think they have in here thrombocytopenia again, or thrombocytosis. We should also pay attention to DIC, disseminated intravascular coagulopathy. Okay. And I want to say that's it. Now, there's tons of other congenital disorders in here, such as Osler-Weber-Reduced disease and giant platelet syndrome and all that. I would say go over those just in case, okay? Because like I said, I want you to study everything because you never know. But the ones that I just told you and the ones I gave in the outline for that week in class are the ones that I really, just kind of focus on with this chapter, because those are things you're going to see a little more clinically. Okay. Questions?
No.
No. Okay. Moving on, moving on, moving on. So 15, this is another one that I was able to just kind of get a clear focus here. So for 15, this is alterations in blood flow. So basically anything that's going to cause, abnormal blood clotting. So there's a couple of concepts here that are very important. Number 1, making sure you know what happens with the difference between venous occlusion versus arterial occlusion. Okay. This information is going to come up again when we get to cardiac in a second. How to distinguish a thrombosis versus an embolism. We should also understand now, getting into the topics, and sometimes people miss this information on how you describe an aneurysm. Sometimes people don't know how to describe an aneurysm, but I want you to be able to describe an aneurysm. An aneurysm is a bulge that occurs in the artery, in the vessel wall. The vessel wall is normally like this. Now it bulges like this. Now, what causes that bulge? Two things. These patients have a weakening of the arterial wall. And these patients also have most likely some sort of pre-existing condition, hypertension or something else that's going on that's causing a lot of blood to pool in that area, maybe pressure rise in that area. Okay, so hopefully you're able to explain what is it, like how to explain what is an aneurysm. Now, the rest of this, we focused on DVT, varicose veins. Please make sure you know everything about those two conditions. I explained this in class as well as in the previous video. Why? Because you're going to see it, I'm quite sure. You should also know the difference between Berger's and Raynaud's. They both have very similar signs and symptoms. However, the risk factors are different. So that's how we should be able to distinguish the risk factors. Okay. Any questions with 15?
No.
No. Okay, wait, I have, uh-oh. Sorry, I missed somebody's questions. Taylor, sorry to interrupt. Will you be able to still post this? Oh yeah, for sure. This is being recorded, Taylor. So just as a reminder, and I'm going to say this again, this is being recorded. So if you have to jump out the tutoring session, if you have something to do, that's fine. I will post this recording later once it converts. Okay, so I'll have this packaged very nicely for you. Okay, and I'll post it. Okay. Okay, great. Oh yeah, yeah, no, so that's okay. Yeah, even though I didn't use, the reason why I didn't use YouTube was because with YouTube, I'm not able to pull up the PowerPoint slides like this, like how I can show you guys information. And, you know, if someone has a question about a particular slide, I can pull it up and, you know, cover the material. And I'm able to kind of type in the whiteboard and everything. So that's the reason why I didn't use YouTube Live, but I will be saving this as a MP4, so I can upload it to YouTube as well. But you will get the recording either way, so you don't have to worry. I will post an announcement with the recording. Okay, so where am I? We're done with this. So yes, cardiac. For my Monday people, because my Monday people need this, because you guys need to take your cardiac quiz. Everyone else did. Okay, so cardiac week was divided into 16, 18, yes, 16, 18, 19, and 20, okay? And so, oh, Laura, you're sad? Okay, don't be sad. We'll get it together. Okay, so for chapter 16, this chapter was divided into two categories, I would say, or two areas, where the first portion just kind of focused on the physiology of how the body regulates blood pressure, whereas with the second half of the chapter focuses on hypertension topic, you know, in a lot of detail as far as the conditions. Now, saying that, please, please, please make sure you know every single inch of this PowerPoint, okay? Not only just, okay, well, I can put a test question here. You know, it's just about making sure you know this information clinically, because how many patients are going to have blood pressure that you're going to see? Possibly every other person, maybe, I don't know, hopefully not. But anyway, you get the idea. So we want to make sure we understand everything about hypertension. So from the beginning, okay, and I'll spend a little more time with this because of the Mondays section people. When we discuss blood pressure, we should understand that blood pressure is measured in an artery. Why? Because when we talk about arterial flow, and this goes back to anatomy, arterial flow is given to actually supply blood systemically to all all tissues, organs, cells, everything in the body. Okay. So that's important to understand why we're measuring arterial, okay, and not venous blood. If we measure venous blood pressure, that wouldn't really tell us much of anything. Okay. So we want to focus on arterial flow. So saying that, we also focus on what's happening inside the heart or with the heart. So when the heart contracts versus relaxing, the amount of blood that leaves the heart when it contracts. So we definitely want to focus on, and I can do a little highlight here, sort of, okay. So we definitely want to focus on this equation here, okay? Not that I'm going to have test questions, or I should say that are, you know, mathematical type questions, but just making sure we understand the relationships between the two. We should also be able to distinguish how stroke volume correlates with systolic pressure and how systemic vascular resistance correlates with diastolic pressure. Okay, that information is important to know. Okay, the next thing here, we went into understanding the direct measurement of blood pressure and indirect. I would go over this just as an example. My mom actually had this when she got out of surgery. They left it in there. So with the direct measurement, they put a little catheter here, okay, in the wrist, and they're able to, you know, just kind of measure the patient's pressure. It's definitely more accurate. It is invasive, okay, but it's only used in surgery. So they do this in surgeries. They left it in there for a little bit while she was in ICU, and then they were able to take it out, okay? So this type of blood pressure measurement is the direct measurement, okay? So we should know this, and we should also know that indirect is the ones that we commonly use with the blood pressure cuffs and all of that, okay? But this one is not always used, direct measurement, okay? Only certain situations like surgeries. Okay, now, this, oh, let me go back to this. One thing that I would say when it comes to understanding blood pressure regulation, overall, we know that there's many factors that can be involved here, neuro and all of that, but I do want you to make sure you focus on renal. And this goes back to physiology. I think we all have an understanding when we talk about kidneys. The next thing you should think of is blood pressure regulation, okay, as well as blood flow regulation, because the kidneys are very important when it comes to that. Now, the physiology of short-term and long-term regulation, please make sure you know these two slides. I can easily have test questions directly from these slides. You should know the flow, okay, of short-term regulation, the flow of long-term regulation. And remember, in the lecture video, I also included the medications that can counteract these normal pathways. So for here, let me see if I can type it in. Well, I don't want to mess this up. Okay, I'll just say it. So for here, we have alpha blockers and beta blockers. for this slide, we have ACE inhibitors, vasodilators, aldosterone receptor blockers, and then we also have diuretics. Okay. Now, let me just stop here for a second. Okay, so those of you who are on the line with me, and I lost a few people, but anyway, those of you who are on the line here with me, does anyone have any questions from short-term and long-term regulation? Just, you know, making sure you have an understanding of this.
For the long term, how does it determine after the angiotensin 2, how does it determine whether it goes to vasoconstriction or aldosterone release?
So after this, it's actually both. It goes both ways. So
Oh, okay.
normally in this pathway, when angiotensin 2 is released, it will cause two things to occur. It will cause the vessels to constrict, and it will also cause on the other side increase of blood volume.
Oh, okay. Thank
So
you.
that's normally what happens. When a patient has an ACE inhibitor given to them, basically it blocks that conversion of 1 to 2, so then nothing else happens below, basically. So then there's no increase, so to speak.
Okay, thank you.
You're welcome. Okay, so I think we're doing good here. Just keep in mind, I just threw this slide in here just to kind of show you the different hypertensive medications and, you know, the definitions of them. I do not need you to know the cost per day. Okay, but as you can see, diuretics are cheap, but we don't need to know the cost per day. All right. So anyway, now hypertension. This information you should know, first of all, the blood pressure classification chart here. So please make sure you memorize this slide, which is slide 13, and it's table 16-2. This is also in your textbook as well. These are the numbers that I will test you on. So I can incorporate this as a question somehow. So just please make sure you know this. Now, when we talk about hypertension, primary and secondary, so just really quickly, primary hypertension is what we consider idiopathic. We don't have a known cause for it. It is the most common form. Most of the times this is distinguished from, or I shouldn't say distinguished, but usually we know that there's risk factors that leads to this. Okay, so I will go over all the risk factors that are listed here. The major issue here is that this type of hypertension can lead to end organ damage. So it is important to know that it can damage the heart, the arteries, the kidneys, the brain, and the eyes. And not only that, but just having an understanding overall as to what could be or why or what is happening with the type of damage with those organs. Okay, so we should be able to have a little bit of an understanding as to what happens with that organ. Okay, I know this flow chart looks really crazy and it's a lot going on here, but you should be able to at least get a, you know, some understanding from it. So I'm gonna just stop here 1 second. Does anyone have a question from this information? Does anyone not understand like what's happening with each organ? Just want to make sure we're clear with this. And again, not only for test purposes, but you know, when your patients are hypertensive, you want to be examining their eyes. You want to listen to their heart. You want to make sure, you know, that they don't have signs and symptoms of a stroke. Okay, so those are the things that we want to be paying attention to when a person's hypertension is not controlled.
I did have a question.
Yes.
Regarding the organs, is it only the organs that are being affected due to hypertension, or is it hypertension and then the organs, or is it the organs that are being, and then it goes down this ladder of things?
Oh,
depending
yes.
on
Okay. Right. I understand what you're saying. Okay. So the hypertension, so you're reading the chart from the top moving down. So basically what they have here in blue is that the person is hypertensive, and they also threw in their atherosclerosis because that can also kind of block flow and cause more pressure. So what's happening here, what they're saying is when a person has hypertension, and let's just assume they're not medicated or nothing's going on. So the person has hypertension, what it could do to the heart and arteries, it can now cause increased workload, cause increased pressure, decreased flow, and so it's just kind of looking at the chart from the top moving down. So how the arrows are going. Does that help?
Okay. Yes, it does. Thank you.
Okay.
So it's not necessarily that it's going to do that to all of them. It's just dependent on whatever organ it's affected
yes.
individually.
Yes, exactly. So yes, it's not happening all at the same time. Hopefully that doesn't happen to any of your patients, that it's not all happening at one time. But so it's just a matter of knowing, that this could possibly happen to one of these organs.
Okay, got it. That makes more sense.
Yeah, so it's not happening all at one time. So sometimes people can have uncontrolled hypertension and it lead to a stroke, while you may have another patient that has an uncontrolled hypertension and they just have an aneurysm from it, So it just depends.
Okay. It's more of like an overshadowing of what could possibly happen depending on which. It makes more sense now.
Yes,
Okay.
exactly.
Okay, thank you.
This is so important to understand this concept, because I can guarantee you it's going to come up again when you get to core. And, this is going to be incorporated with your assessment with your patients, when their hypertension's not controlled. Okay.
Okay, thank you.
You're welcome. Okay, so we have a couple other things here as far as treatment interventions, and you can kind of look over that. Secondary is pretty straightforward. There's a primary condition, then it leads to hypertension. We should know this as well. And then we have a little bit of information here on hypotension, which it wasn't much. Okay. So I think I still have maybe a few people here from the Monday group that didn't take their cardiac quiz yet, or anyone else for that matter. Does anyone have any questions from chapter 16?
Is the low
No, thank you.
sorry, the low blood pressure slides, are they like important to know for the test, or just
Yes,
Okay.
it is important, even though it's not a lot of information. So what I would focus on here is making sure you know, first of all, when we discuss low blood pressure, what they have titled here, orthostatic or postural hypotension, meaning that when a patient, has certain movements, certain positions, okay, the blood pressure could drop. And they give you here the range that it could drop. I'm not going to test you on the ranges, but just know that their blood pressure can drop through movement. The rest of this focuses on what it could be a result of, or what could possibly cause it. So I would look over those items, okay, because I could have a question possibly with that. You should also know when they do have this low blood pressure, and it's not listed here, but you should also know what could be possible signs or symptoms. So these patients can have like syncope, kind of like a lightheaded feeling, or, like the room is spinning. They could also be a very high fall risk, these patients, because they are lightheaded, So just kind of things like that we should know, and they, kind of cover a little bit of that with the treatment as well, to kind of make sure they don't fall, okay, things like that.
Okay, thank you.
You're welcome. Okay, so I think we're good here. Oh, what did I do? I'll just say save. I don't know what happened. Okay. Boy. Okay, yeah, my plan was to have 2 tutoring sessions, one Thursday. No, I forgot what I was going to do. One Thursday and one Saturday, something like that. But things just, being in a hospital was a little longer than I expected. Okay, so anyway, chapter 18, cardiac. So I think, let me do this. Give me 1 second. I'm going to share something different. And this will help a lot of you. do this. Clear. Uh-oh, don't start. They're saying my internet connection is unstable. I'm doing so good this evening. I don't want anything to start. Okay, yes, I'm back. I'm back. I don't know what happened. Okay, let me just do a mic check. I see it's doing good. Okay. I was trying to do something, but that's okay. Let me just do this. What are you showing me, Nicole?
What you're trying to draw.
Oh,
drew
thank you. Yes. Yeah.
Exactly what you drew is what I drew out.
Yes, that's what I was trying to do, but for some reason, this Zoom meeting that I'm using didn't like that, so it shut everything off. Yeah, Nicole, if you can do me a favor, I don't know if you can screenshot that for me, or not right now, or copy it, maybe take a picture and email it to me or something somehow, if you don't mind doing that for me later. Not right this moment, but whenever you get a chance. Just so that way I can share it to others that may need help with that area with cardiac. So let me just go over verbally what I was trying to do. So for those of you who are looking at chapter 18, what's going on in this chapter is divided into understanding coronary artery disease first. The second half goes into valvular disorders. And then the third portion of it goes into what we call infections of the heart. Okay. Excuse me. So what's happening here? In the first portion of this chapter, I know it went over a lot of detailed information. You're kind of like, okay, well, we're talking about this and then another topic and another topic. But I want you to understand about the first few slides, maybe first 10 slides or so, it's basically all talking about a common theme here, okay? So just to kind of go in order, the first thing I want you to understand is that we are discussing what's considered, or the topic, atherosclerosis. Atherosclerosis is defined as plaquing in an artery, okay? Arterial sclerosis, just as a side note, arterial sclerosis is plaquing in the arteriole, okay? Just in case if you see that term. Now, getting back to atherosclerosis, atherosclerosis is lipid plaquing in the artery. So how do we know this? How do we get there? One of the major risk factors is definitely diet high in saturated fats. So when we discuss diet high in saturated fats, what are we talking about? In-N-Out, Raising Cane, Krispy Kreme, you know where to go, okay? So we're talking about those types of things that we all love to eat, but unfortunately are not good, okay, for us. So the problem here is that the more that we have a diet high in saturated fats, this will unfortunately increase the lipid content in the bloodstream. Now, how do we know that? Well, this is where your labs come in. Okay, so as a nurse, you'll be able to look at what's happening with the patient's lab studies, and in particular, we're looking at a lipid panel. So with lipid panel, we're looking at cholesterol, triglycerides, LDLs, and HDLs. Please understand, I do not need you to memorize the numbers, but I just want you to know that that is considered what we call a lipid panel. HDLs, LDLs, triglycerides, and cholesterol. Now, in the video, I go into detail explaining the purpose of HDLs and LDLs and what they do and what we're looking for here, or what we would want, you know, normally in a patient. So I would cover that material as well. Now, once we understand that, okay, and come to a situation where, let's say a patient has atherosclerosis, and let's say that plaque, that lipid plaquing is happening in the coronary artery. That's not a good situation, because we know from anatomy that coronary arteries supply blood to the heart muscle tissue. So if there's a lipid plaquing in the coronary artery, that means that that's going to block blood flow getting into that cardiac muscle tissue. That doesn't mean the patient is going to lead to a heart attack right at that moment, but it could possibly lead to that. Okay, so we'll get to that in a second. So once a person has a blockage of blood flow get into the cardiac muscle, the physiology of it is that this cardiac muscle is not getting oxygenated blood flow. What's going to happen if your cardiac muscle tissue, just the physiology of it, is not getting oxygenated blood flow? It's going to go the anaerobic route. And what can this lead to is this patient having what we call an angina. Angina is a clinical term for chest pain. All it means is that there's not enough oxygenated blood flow getting to that cardiac tissue. That does not mean they're having a heart attack at that moment. It just means they're having angina. Okay. And if you watch my video, and I did post this link for everyone, I think I went into detail with this with the check your understanding, not check your understanding, the discussion board question. It had something to do with this. Okay. So, you know, I already went over that there. Now, when the patient has angina, they're having chest pain. Your book describes this as, you know, what we consider chronic coronary syndrome, acute coronary syndrome, stable angina, unstable angina, you know, just trying to distinguish, okay, which is which and what's happening. Just to kind of jump to this, when a person has chronic coronary syndrome, it means that the lipid plaquing, whatever it is, they have the blockage in the artery is pretty stable in a sense where that plaque isn't moving, it's not doing anything. Whereas with an acute coronary syndrome, this patient has a lipid plaquing in the coronary artery, but now let's say, for example, this plaque gets larger or there's some sort of change, and now the patient is going to have more acute signs and symptoms. So let's say the chest pain is really intense, or, you know, when they sit down and, you know, try to relax, it's not calming down, you know, so it's just like an intense chest pain that is not easy to get away right at that moment. So again, we don't know if the patient is having a heart attack at this moment. So the title is what we call an acute coronary syndrome. Now, from an acute coronary syndrome, in order to distinguish if they're having a heart attack, which is also known as a myocardial infarction, we must look at two things to distinguish. The blood work, looking at cardiac biomarkers, or looking at the ECG. Okay. The ECG, I just want to clarify, is not a determining factor that the patient is having a heart attack. It just kind of tells us how much damage has occurred. The cardiac biomarkers, the blood work, is what tells us exactly that this patient is having an MI, and it's actually the most definitive test. So just to confirm, for cardiac biomarkers, what we are only focusing here is troponin. We're only focusing on troponin. Please make sure you know this. I know the labs, I think the lab sheet I gave you guys, it had creatine kinase on there as well as troponin. Just keep in mind, we are only focusing on troponin because creatine kinase can be in other muscle tissues as well. But troponin is more focused on cardiac muscle tissue. So, yes. Those of you who are on the line, does everyone understand why troponin is in the bloodstream, why it's released when there's cardiac muscle tissue death?
I think it had to do with the breakdown of the muscle, right?
Yes,
Yes.
It
exactly.
releases the troponin into the bloodstream, therefore it's what picks up when it's
And
Exactly.
troponin is
Yes.
on
Yes, yes, and yes. Okay, so very important to know that when a person is having a heart attack, a true heart attack, there's no blood supply whatsoever getting to that area of the heart muscle tissue. That area of the heart muscle tissue does become sort of undergoes a necrosis, so to speak, which means that that tissue starts to break down. Once that tissue breaks down and it flows through the rest of the body and circulation, it breaks apart the muscle fiber, the sarcomere, actin, myosin, all of that. Okay, I know we don't want to get there, but troponin is part of that, which means that it's going to be released in the bloodstream as well. Okay, and that's our determining factor. Now, the rest of this information, and let me just kind of go to that slide. Oh yeah, I forgot. I gave you guys the PowerPoint with all my notes on here. So everyone should be good to go. Okay, so this slide shows you the different types of MI. So we discussed STEMI, what's considered just an unstable angina, and then STEMI. So the major difference here between a STEMI and a non-STEMI is that on an ECG, the ST elevation is happening with the STEMI, and then with a non-STEMI, the ST elevation is, not there. That doesn't mean the patient, when you have the ECG comes back clear, that does not mean the patient's not having a heart attack, because you must look at the cardiac biomarkers, because that's a definitive test. Okay. Is everyone comfortable with this information on this slide right here before I move on?
Yes.
Yes. Okay, good. What is that? Okay. Very good, very good. Okay. So let me move on to the next area here, which is valvular disorders. So for the valvular disorders, I think there was about 5 or 6 we went into. Please make sure you know the name of the valvular disorder, what's happening. So if it's like a regurgitation or stenosis, or a sense where there's blood building up in the chamber, or, not moving forward or whatever. And then also knowing what it could lead to, like in this situation here, it could lead to chronic pulmonary hypertension, and then right ventricular hypertrophy, right-sided heart failure. Okay. So just to confirm, I will not be testing you on the sounds. I left the description here in the PowerPoint so you guys can reference that later when you get into your nursing classes, but I will not test you on the sounds. I don't have the capability of putting that on the exam. Because it'd be better to hear the actual sound. Okay. So that's that. In the chapter for this chapter, in that video, I believe I did draw like the heart on the board, and I had everything color coded with the different ones. So if you are still needing to understand these topics individually, I would recommend that you draw out the heart like on a big poster board, and then just kind of, color coded, okay, mitral stenosis is in red, and just kind of highlight where in the chambers they're going to have a buildup of blood or whatever's happening. Okay. For those of you who are visual learners, I think that's a good thing to just kind of get some poster boards and, have the heart really big. And also, just a side note, when you take the midterm exam, you do have scratch paper that will be given to you, so which is on the back of your honor code. So if you have, you want to draw out the heart, or you want to write out any information, like, to kind of help work out your problems with your test questions, you can use the scratch paper. Let me see, there's a question here. Can't find it now. Oh my gosh. What did I do? Oh, you want a picture? Oh, okay. You want a picture of, I'm looking at Madison and Ryan's question.
Was the on the video you were drawing out the heart, and then you were trying to color code it, but it looked like the room was dark, and you were in the dark doing it, so it's kind of hard to see what you were
Oh,
doing.
oh, okay. Oh, yeah,
And
yeah.
it was what you were describing about like the one color doing one thing and then the other doing the other. It was really hard to see.
Okay. That, let me see. Okay, give me a second. Hold on. I want to do this and I'm afraid. I'm afraid because I didn't like my drawing before. Oh gosh, I don't know how this is going to go. I know this looks all kind of crazy. Just bear with me. I'm just going to do it right now because I don't know where else I have this somewhere in the video to show you, you know, where it's at. Okay, so what I'm drawing here right now, the first thing I'm drawing is mitral stenosis, okay? So on the left side, we know that this particular valve between the atria and the ventricle is the mitral valve. What I drew here is the valves just kind of closed together, okay? And let's just imagine that it's, in a sense, when we say stenosis, I want you to think of it not opening completely, okay? So this is just an exaggerated, not that it's completely closed and that's it. It's just that sometimes it doesn't open all the way. So what happens is this. When you have this situation, the problem here is that blood will start to pool up in this particular chamber here, the left atrium, okay? Which means that, you know, blood is not moving forward, okay, here in the left ventricle. Oh, and I forgot to draw my vessels here. Uh-oh. Let me go back. I know this is not a pretty looking. It's always hard using the the drawing method here. Okay, but you guys get the idea. Okay, so now that it's building up here, the problem is it's actually going to continue to build up in the pulmonary veins. It can even back up all the way, and I'm just going to imagine that we come over here now and back up into the pulmonary artery and back up into the right ventricle. And when it backs up into the right ventricle, the issue is this. When it's time for the right ventricle to push blood forward, because remember, it's supposed to go to here, the pulmonary artery, it cannot because now blood is kind of building up backwards. So the problem here, the right side of the heart is now going to fail to do its function. So these patients can lead to what we call a right-sided heart failure. Just as a side note, when you look at each valvular disorder, the chambers where the blood is backing up to and there's blood just kind of building up or stagnant there, it can make those chambers also get enlarged, which is why you see that it can lead to ventricular hypertrophy. Okay. That's mitral stenosis. Oh, I didn't mean to do all that. Oh my gosh, look at me. I don't know how to do this. I need an actual board. Okay. This may not work because this is going to take time. I'll figure something out. Okay. Let me just clear this.
Thank you for doing that. I appreciate it.
Yeah, no, I only did the first one, but I'll figure something out. and try to send it. Okay. I just don't know what, but I'll figure it out. Okay, you're welcome. No problem. Okay, so let me get back to the, what was I sharing? The PowerPoint. Let me get back to that. Okay, I like this Zoom meeting because it makes, I can do multiple things with it, which is good. Okay, so once we finish with the valvular disorders, and like I said, you can easily do this at home. So, you know, just what I did, just take the heart and draw it. And then as you read what's happening here, just put that, you know, visual in the drawing, you know, so blood flow is backing up into this chamber and that chamber. And then that way you can actually see what's happening. And then the very last thing that we had in chapter 18 was focusing on infections of the heart. So we had 3: infective endocarditis, rheumatic heart disease. Sorry, let me start there. Rheumatic heart disease, infective endocarditis, and myocarditis. So rheumatic heart disease and infective endocarditis are both bacterial infections. Please make sure you know the bacteria that's causing this. I will say this from here on out. If you see a condition that's an infection and it's caused by a bacteria, please make sure you always memorize that bacteria, because I can easily put that as a test question. And then myocarditis, I really didn't give you much information here. I just wanted you to know that it's viral caused, and that's it. In the overall thing here, what happens with myocarditis is that the myocardium changes and it can stretch out and, you know, not function, and that's basically it. Okay. So does anyone have any particular questions with chapter 18? I know I lost a lot of people because I guess no one expected this tutoring session to be 2 hours long. I didn't expect this to be 2 hours long either, because it's almost 1 o'clock in the morning for me, but it is what it is. Okay, so let me stop this. Where are we now? 19. Okay. So for 19, very important to know everything here. Number one, why is this? Number one, why is my PowerPoint slide looking like this? What the heck did I do? Okay, well, anyway, I'll just do this. Okay, so we're chapter 19 with heart failure. Make sure you know the possible causes. It kind of goes over some background information here, okay, with that. Possible etiologies. Excuse me. Make sure we know the compensation. The compensation of any kind of cardiac disorder is going to be sympathetic nervous system activation, which is talked about here in this slide. This information is important to know not only for heart failure, but also for any other cardiac conditions, which I believe I mentioned that in previous slides. If you are not comfortable with this, I usually tell everyone to please start memorizing this first before you get into the actual signs and symptoms of what is considered right-sided and left-sided heart failure. Because if you don't understand this or have this memorized, it's not going to make sense, okay? So I put in this PowerPoint like a lot of different, you know, flow charts and cartoons and things like that to help you. And I think this usually helps people memorize information. When it comes to left and right-sided heart failure, what I'm really looking for here is making sure you guys know what are the signs and symptoms for backward and forward effects, and how that correlates to the blood flow circulation. So when we talk about backward effects, saying that something is being blocked or backing up, or what's happening going backwards, as to what's happening going forward in that situation. It is distinguished between right and left side. So as you can see, this patient looks different than this one, okay, because the signs and symptoms are going to be quite different. When we discuss right-sided circulation, right-sided heart failure, we are looking at things that's going to back up into the venous system. So these patients are going to have signs and symptoms of venous congestion. When we look at left-sided heart failure and the backward effects, we're looking at things that's going to back up into pulmonary circuit. So these patients are going to have pulmonary signs and symptoms. Moving forward for forward effects, it's the same for both, okay, right and left. Patients can have biventricular. You should also know the diagnostic testing that is used and the purpose of the treatment goals, basically. Just to also add in, for this chapter, we did add in a term here called call pulmonale. Oops, I can't highlight this. Sorry. So it's in this slide. There's a term called call pulmonale. Please make sure you know that term, okay? Just in case if you are tested on this. And escape this. I think that was about it. Any questions with heart failure, chapter 19? So I know I kind of breezed through that, but if anyone that's, if you guys that are on the line have any questions with or something you need me to explain in more detail, I can definitely do that. Okay, so I'll take that as a no. So I know we're all tired. So this is the last chapter for the night. So chapter 20, this chapter focuses on shock. Okay, so what is shock? You should know and pay attention to, first of all, the definition of shock or what it means. Okay, so we know that this is due to a lack of blood flow or hypoperfusion, not enough oxygen to cells. Okay, we should also know box 20-1, and I said this earlier in the layout. Please make sure you memorize this information here, and this is also in your textbook. This gives us more breakdown of pathogenesis. We should know this. And compensation, again, which comes up with any cardiac condition. And then now, when it comes to the different types of shock, I'm going to tell you, and I'll use this box here, which ones I focus on. I focus on hypovolemic shock. Very important to know if a patient has, hemorrhaging or fluid loss, blood loss, that they could go into a hypovolemic shock. You should know the different examples. Hemorrhaging can be internal or external. Dehydration from vomiting, diarrhea, overuse of diuretics, which can happen sometimes with people that are in the bodybuilding arena. Burns, when a patient has a burn or burn victims, they lose fluid. And pancreatitis patients also can lose fluid from the vomiting, okay? Please make sure you know, hypovolemic shock. How do you treat it? Give the patient fluids or blood. If they're losing blood, give them blood. If they're losing fluids, give them fluids. Okay, so pretty simple. Distributive shock, you should definitely pay attention to because I want you to be able to describe overall what is distributive shock. This is basically an extreme vasodilation that happens in the vessels. If you have extreme vasodilation, this leads to hypotension, lack of blood flow, lack of circulation. So, number one example here, anaphylaxis. We talked about this in chapter 10. We know what anaphylaxis means. This is type 1 hypersensitivity. If it goes on too long, this can lead to a person having anaphylactic shock. Neurotrauma, spinal cord injuries, and spinal anesthesia, I'm going to clump those together. Sometimes people can have damage to the nervous system, whether it's from some sort of trauma or, you know, spinal anesthesia issues. And then that leads to, you know, this extreme vasodilation. And then definitely sepsis. Sepsis is a widespread infection that happens in the body, which can lead to this type of shock as well. Cardiogenic, I think, kind of self-explanatory. And obstructive shock is also because what's happening here, there's some sort of mechanical blockage, blocking blood flow. So if you just kind of have an overview of what's happening here with each one, you should be fine. Keep in mind, just to kind of end this off, as you guys know, I don't get too crazy with treatment questions. My questions are more focused on risk factors, signs and symptoms, pathogenesis, which we definitely need to know for this course, and understanding signs and symptoms as well, okay? Treatment questions, if I do have a treatment question here or there, it's gonna be something that's really straightforward, okay? So like if the person's lacking something, then you give them that, okay? Now, I'm done. I hope this helped. Does anyone have any last minute questions, any topics, anything that you need me to go into detail with before we end this recording? Someone has a question. Okay, Kendra says, oh, thank you so much. Oh, yes. Oh, no problem. No problem at all. You're welcome. I just wanted to make sure that everyone, you know, was comfortable getting ready for the midterm. Okay. Okay, I'm glad it helped. Okay. I wasn't sure if you needed more detail. Okay, so.
Week 4, I'm sorry.
Oh, yes.
The week 4 activity that we were giving, is there something specific that you're wanting? And also, for whatever reason, when I uploaded mine, it looks like it's not all the way on there and I can't resubmit it. I don't know why.
Okay, if you are not able to, yeah, I don't think you can resubmit with that. So just hold on to it until I get back. I'll take a look at what you uploaded. I should still be able to grade it, so don't worry, I can still put your grade in. But if for some reason it's missing something, you can just hold on to the handout and give it to me when I get back.
Okay.
And you had a question about one of.
Well, I was wondering, like, was there something you were looking specifically for, like,
For which question?
for like, okay, so for example, for number 4, I wrote like a huge paragraph on it. And it says, what is the rationale for using thrombolytics in the management of STEMI? What were you looking for there? I just said that like it dissolves clots quickly, can stop heart attack. It lyses fresh clots.
Yes, that's exactly what I'm looking for. So if the question, I don't remember what the question was, but if the question is just based off of thrombolytics, just explaining what that medication is doing, that's all.
Okay, I just wanted to know if there was.
Yeah, so thrombolytics just gonna break up the clot. It can be used definitely in situations if a patient has coronary artery disease because of that lipid plaquing, or it can also be used in situations where patients have a stroke as well. Okay, when they have like a ischemic stroke because there's some sort of blockage. And that's basically all I was looking for. I think that same information was in the discussion board question with the guy that had the heart attack. I think, because we discussed in particular TPAs. Is that the question? It's talking about a type of TPA.
No, but we answered it. I put that. So exactly what you said. I put that. I just wanted to know, is there something more that you maybe wanted? Because I was trying to be.
Oh, no. Just what you put there is fine.
Okay.
Okay. So if there are no more questions, I'm gonna call it a night. And so you guys have a good night. I hope this tutoring session helped you. If you have any questions, don't hesitate to email me. I will still be available, okay, as you guys notice, even though I'm not there physically. So yeah, so just email me if you have any questions. I will post this recording as soon as it converts. Since this video is about 2 hours long, and it's after, actually it's 1:05 in the morning here. I most likely won't post this until tomorrow morning, the recording, because it's going to take a little time for this video to convert. So, but I will have the recording posted. Okay, so you guys have a good
Thank you.
night. And again, thank you for your patience with everything.
Thank you.
You're welcome.
Thank you so much. That was very helpful. Thank you.
You're welcome. No problem. Okay, bye-bye.
Okay, bye-bye.
Oh my God. Oh, that was intense.